Hello, and welcome to the Congressional Hispanic Caucus Institute's 2022 Graduate Fellowship Program Capitol Hill Briefing Series. I'm Marco Davis, President and CEO of CHCI. This series is the culmination of CHCI's premier 9-month graduate fellowship program, which offers exceptional emerging Hispanic leaders unparalleled hands-on experience in public policy. This unique fellowship program seeks to enhance participants' leadership abilities, strengthen their professional skills, and increase the presence of Latinos in public policy areas, most notably in the areas of health, technology, housing, energy, social equity, child welfare, and education. CHCI is thrilled to be able to offer our graduate fellows the opportunity to share their perspectives on policy issues that they're passionate about and convene leaders in this work for an informative conversation. Now, we'd like to thank our graduate fellowship program sponsors for supporting the program, including Facebook, the PepsiCo Foundation, America's Health Insurance Plans, BBVA, Casey Family Programs, the Walton Family Foundation, the American Petroleum Institute, DaVita, Wells Fargo, and CVS Health. You can keep today's conversation going by using the hashtag CHCI Fellows on social media. And please visit chci.org to learn more about our graduate fellowship program, as well as our other leadership programs and special events. And we encourage you to reach out to our fellows via LinkedIn to find out more about their policy work and help them connect with job opportunities for when the program concludes in May. Now let's get to the briefing. Enjoy the discussion.
Hello, my name is Caroline Gonzalez-Scott, Vice President of Programs at CHCI. Join me in welcoming Congresswoman Lucille Roybal Allard, representing California's 40th District.
Good afternoon. I'm Congresswoman Lucille Roybal Allard, representing California's 40th Congressional District. On behalf of the Congressional Hispanic Caucus Institute, thank you all for attending today's Capitol Hill policy briefing session entitled Quality of Care for All, Addressing the Gaps in Quality of Care for Undocumented Immigrants in the U.S. Healthcare System. As many of you know, my father, the late Congressman Edward R. Roybal, was a founding member of the Congressional Hispanic Caucus and the Congressional Hispanic Caucus Institute. He envisioned that through legislative, executive, and judicial actions, the voice of Hispanics would be advanced. Today, the Congressional Hispanic Caucus and the Congressional Hispanic Caucus Institute continue to work together to prepare the next generation of Latino leaders through their internship and fellowship programs. It has been my privilege to host dozens of the CHCI interns and fellows in my office over the last 2 decades. They are truly amazing young men and women, and I am enormously encouraged that the future of our communities is in good hands with these emerging leaders. This statement could not be more true about the moderator of today's panel, Michelle Paucar. Michelle is CHCI's current CVS Health Graduate Fellow, and she has spent the past year supporting the legislative team in my office with public health and women's issues. Prior to joining the fellowship, Michelle received a Master's of Public Health with a concentration in public health policy. She has worked in local and federal health agencies to help protect and promote the health of all individuals. Her experience as a daughter of undocumented immigrants has shaped her interest to pursue a career in public health policy to help ensure access to quality health care for everyone in this country, regardless of race, geography, or immigration status. Thank you, CHCI, for placing this outstanding young woman in my office and for organizing this year's Capitol Hill Policy Briefing Series to highlight Michelle and all the other emerging fellow leaders. Today's session focuses on the disparities in quality of care for undocumented Latino immigrants. In recent years, quality of care in the United States has improved across several quality measures. Yet racial and ethnic minorities continue to experience worse quality of care, which leads to medical mistrust and poor health outcomes. Michelle has brought together a panel of experts that will provide invaluable insight, stories, and experiences on the existing disparities in quality of care for our Latino community. Thank you to everyone on the panel for your continued work and commitment to ensure that underserved communities receive the quality of care they need and deserve. And to all of you viewing this briefing virtually, I thank you for joining us and for your interest in improving access and quality of care for all our communities. It has been my privilege of a lifetime to fight for these issues over the nearly 30 years I have served in Congress. As I retire at the end of this Congress, I am confident Michelle and all the CHCI's current and former alumni will ensure that the work will go on, the cause will endure, and the dreams will never die.
Thank you, Congresswoman Lucille Roybal-Allard, for a kind introduction. As co-founder and co-chair of the Congressional Public Health Caucus, we thank you for your work in promoting evidence-based community public health and wellness programs. I would also like to take this opportunity to thank you for your 30 years of service in the House of Representatives. As the first Mexican-American woman elected in Congress, Congresswoman Roybal-Allard has championed for the people of California and has spearheaded legislation on immigration, healthcare, and labor. Again, my name is Michelle Paucar, and I am the 2022 CHCI CBS Health Graduate Fellow. It is with great pleasure that I welcome you all to the 2022 Congressional Hispanic Caucus Institute Capitol Hill Briefing Series. I am honored to be moderating today's conversation on the existing gaps in quality of care for undocumented immigrants in the U.S. healthcare system. Healthcare quality is defined as a degree to which health services can improve the prospects of individual and population health outcomes. According to the 2019 National Healthcare Quality and Disparities Report, quality of healthcare has improved from 2000 to 2018 across several improvement measures, such as person-centered care, patient safety, healthy living, effective treatment, care coordination, and care affordability. However, the report also indicates that inequality across quality measures for racial and ethnic minorities have continued and even worsened. For instance, African Americans and Native Americans and Alaska Natives are reported to receive worse care than whites for approximately 40% of quality measures. Additionally, Hispanics are reported to experience worse care than non-Hispanic whites for nearly 35% of quality measures. In comparison to non-Hispanic whites, Hispanics are more likely to obtain substandard quality care due to discrepancies in insurance coverage, healthcare access, and language barriers. As of 2019, 11 million undocumented immigrants were estimated to reside in the U.S., making up 3% of the U.S. population. And with the exception of emergency Medicaid, undocumented immigrants are not eligible for federally funded public health insurance programs, including Medicare, Medicaid, the Children's Health Insurance Program, and the Affordable Care Act Marketplace. Undocumented immigrants are qualified, however, for state or locally funded programs and limited private coverage via their employer, their spouse's employer, and private plans outside of the ACA marketplace. Research shows that undocumented Hispanic immigrants are more likely to report receiving fair or poor quality care in comparison to US-born Hispanics. For marginalized communities, such as the undocumented, poor quality of care is said to result in worsened health outcomes, increased costs, underuse or misuse of services, and mistrust of the healthcare system. In today's conversation, our panelists will discuss the conceptualization of quality of care. They will also examine the health and healthcare experiences of both documented and undocumented Latino immigrants, and highlight the work that local public hospitals and community health centers are doing to improve the quality of care that's provided to undocumented patients. I will now proceed to introduce today's panelists. First, I would like to introduce Carla Silverman. Carla is Associate Director of Complex Care Delivery at the Center for Healthcare Strategies, where she leads work that focuses on improving healthcare for low-income and historically marginalized populations. She is also an adjunct professor at the NYU School of Global Public Health, where she teaches a graduate course level care on value-based care. Carla began her career in healthcare as a certified nurse midwife at the Community Healthcare Network, a federally qualified health center in New York City. Carla, welcome to today's briefing. Second, I would like to introduce Dr. Adolfo G. Cuevas, who is the Gerald R. Gill Assistant Professor of Race, Culture, and Society, and the Director of the Psychosocial Determinants of Health Group at Tufts University. His work primarily focuses on the intersection between race and ethnicity, psychosocial determinants, and health disparities. His work has been published in scientific journals such as the Proceedings of the National Academy of Sciences, Brain, Behavior, and Immunity, and the American Journal of Public Health, and featured in HuffPost and NPR's Code Switch. Thank you for joining us today, Adolfo.
Thank you.
Third, I would like to introduce Helen Arteaga Landaverde, who is the Chief Executive Officer at New York City Health and Hospitals at Elmhurst, a Level 1 trauma center and community hospital serving over 1.2 million people in the borough of Queens. She is a former Assistant Vice President at the Queens Network and Executive Initiatives at Urban Health Plan, a network of community health centers located in 3 boroughs across New York City. Along with Paloma Hernandez, the President and CEO of Urban Health Plan, Helen opened Plaza del Sol Family Health Center in June of 2009, which has since provided care to more than 29,000 patients, regardless of their ability to pay. Helen, welcome to this briefing.
Hi, everybody.
Lastly, I would like to introduce David Roman, who is the Director of Development and Communications at South Central Family Health Center, a nonprofit federally qualified health center that provides care to more than 25,000 patients. As a key member of South Central Family Health Center's senior management team, it is Mr. Roman's privilege to create bridges between patients, communities, and key governmental, business, and philanthropic stakeholders to support primary medical, dental, and behavioral care services. Welcome, David.
It's a pleasure to be here. Thank you.
Before starting our conversation, I would like to invite our audience to submit their questions on the chat feature, as we will address those later in the program. Please feel free to engage with any of the panelists, and remember to direct each of your questions to a specific speaker for the sake of time. Well, let's get to our conversation today. I would like to invite Carla for our first set of questions. Carla, can you please define the term quality of care? And can you share what the current state of quality of care looks like in the US?
Sure. Thank you so much, Michelle. It's so wonderful to be here. Thank you for having me. I'd like to have us all take a step back and think about, what does this term quality of care really mean? Quality of care is about how we evaluate and assess our healthcare system. But once you ask the question, what is quality of care, or what does high quality care look like, you're faced with a host of additional questions to answer. For example, how should we measure high quality care? And does high quality care look different for different populations and people? And what are the factors that affect the quality of care in this country? And finally, how much of healthcare is about the actual healthcare that we deliver, and how much is it about other factors, such as where people live, the neighborhood that they're in, the job that they have, the air that they breathe, things that we would call social determinants of health that have a very large impact on people's health. In the next few minutes, I want to take you through some different ideas about how we think about quality of care. And then I want to share some information about the general health in our country. Next slide, please. Do we have slides? Okay, I think we're gonna riff for a moment while our slides come up. But maybe I'll keep talking because I know our time is short. So in 2001, the Institute of Medicine put forth a definition of high quality care. And what they said is that it should include 6 qualities. And those qualities are that it would be safe, meaning it doesn't harm you, that it's effective, meaning the care that you receive is supported by scientific evidence and usually achieves positive outcomes. Thank you. That it's patient-centered, meaning that it meets and centers your needs and preferences, that it's timely, you can obtain care when you need it. It's efficient, meaning the time you spend getting care is well spent and directed towards getting you better and improving your health. And finally, that it's equitable. High quality care that's accessible to all patients when they need it and does not vary in quality because of personal characteristics such as gender or ethnicity or race or geographic location or socioeconomic status. Next slide, please. When we think about high quality care, we might also think about a term that's used in our field frequently, and that is value in healthcare. A lot of people in healthcare have spent a lot of time thinking about what value looks like. The Institute for Healthcare Improvement first developed something called the Triple Aim Framework in 2007. And that framework, sorry, can we go back to the next slide? Thank you. That framework said that high value care should be the provision of better care that produces better health at the lowest possible cost. The idea of trying to improve the patient care experience, improve the health of the population, and reduce cost at the same time was actually considered quite radical. It took years for a concept like this and the words that were used to describe it to enter the healthcare mainstream. However, since then, many in healthcare and the policy world believed it was important to add a 4th and a 5th aim. One was to address the growing challenges we have around burnout in the healthcare workforce. The other was to address the significant inequities that we have in our healthcare system and in the health of our country. So the 4th aim that was added was workforce well-being and safety, and the 5th is health equity. And I personally think that was a great idea. Next slide. So here's another way to think about high quality care, and I want to cite Barbara Starfield, who is a pediatrician whose life's work focused on primary care and was one of the first people to introduce the concept of health equity into the healthcare field. These core principles that you see on the screen have been used by others in the field to measure high quality primary care and high quality healthcare in general. And that's continuity of care, comprehensiveness of care, coordination of care, and first contact care. Next slide, please. Another way to think about high quality care, we can look at something called the patient-centered medical home. And these are the principles around the patient-centered medical home. Organizations in the US can use this framework to design or redesign how they deliver care. And most in the field generally believe that these approaches, if implemented and carried out effectively, can lead to better, higher quality care. Next slide, please. So what is the quality of care in the US? I'm going to answer this question indirectly and talk about health in the US as opposed to healthcare, because the two things don't have the relationship to one another that you might imagine. This is a quote from Sandro Galea, a physician and the dean of the Boston University School of Public Health. By most measures, American health is worse than that of any other rich country in the world. Next slide, please. So some sad statistics. Child mortality in Finland is 2 per 1,000. Child mortality in the United States is 7 per 1,000. A child born in the US today can expect to live until age 79. A child born in Singapore today can expect to live until 83. A child born in Japan today can expect to live to the age of 84. Next slide, please. The US spends more on healthcare as a share of the economy, nearly twice as much as the average OECD country, yet has the lowest life expectancy. We spend 8 times as much as Qatar, and for that, we get 6 more months of average life expectancy. Next slide, please. We by far have more adults who suffer with multiple chronic conditions than any other comparable rich country. Next slide, please. Over 30 million people, or almost 10% of the US population, has diabetes. Over 84 million people have prediabetes. And in 2017, the total cost of treating diagnosed diabetes was $327 billion. Next slide, please. Just as a measure of health, our rates of obesity, which can have a significant impact on health, are higher than all other wealthy countries in the world. Next slide, please. Maternal mortality, we're doing poorly, and it continues to get worse. Compared with their own mothers, American women today, are 50% more likely to die in childbirth, and the risk is consistently 3 to 4 times higher for Black women than white women, irrespective of income or education. Next slide, please. And sadly, we have the highest suicide rates in the world. Next slide. And just to get you thinking, we rank as one of the top 3 countries to do the most MRIs, suggesting that despite our love of technology and tests in the US, using more technology or having the most advanced technology is not linked to quality of care or health the way that you might expect. Next slide, please. We have high rates of health disparities in our country. Health disparities are defined as differences in the health or outcomes of different groups of people with the same conditions, or differences in the prevalence of certain conditions among certain groups. Next slide, please. So these are random, but I just want to give you some examples of some striking health disparities by race and ethnicity in the US. And I think the folks that are following me will be building upon this. Black adults are 77% more likely to have diabetes than non-Hispanic white adults in the US. Hispanics are 66% more likely to have diabetes than white adults. Black women with breast cancer have an 80% 5-year survival rate, whereas white women have a 91% 5-year survival rate after diagnosis. Disparities in teen birth rates, infant mortality rates, and HIV or AIDS diagnosis and death rates are particularly large for Black, Hispanic, and Indigenous people in the US. Next slide, please. So what impacts health? Is it all about the quality of care? Social determinants can have both direct and complex effects on health. Levels of income and education shape a range of health outcomes, such as the prevalence of chronic disease and life expectancy. How much social support one has profoundly affects health and well-being, and healthcare is only one relatively small component that influences health outcomes. Social determinants of health affect everyone and shape their needs. Next slide, please. What drives our health disparities? Social risk factors and adverse social determinants of health, bias, and racism, be it personal, structural, and institutional, systemic, and historic. So I want to leave you with this one last slide before I turn it over to my colleagues. Next slide, please. Perhaps you have seen this. It's an idea to help you think about health equity. So on the left, you'll see a portrayal of what we would call reality, how things are now. To the right of that, equality, the idea that everyone benefits from the same supports and gets equal treatment. And you can see that doesn't necessarily lift everyone up to the same level. To the right of that, equity, thinking a little more in a sophisticated way about giving people the supports that they need, which may be different depending on who you are. And then finally on the right, liberation, removing systemic barriers so that everyone can achieve and maintain health, as well as have access to high quality care when they need it. Thank you so much.
Wonderful. Thank you so much for this information, Carla. Now, I would like to invite Adolfo to this conversation and ask, what is the current state of Latino health in the US? And if I may add, can you please tell us what effect can factors such as immigration status, discrimination, and anti-immigration policies have upon Latino health outcomes? Please take it away.
Great. It's a great question, Michelle. Thank you for hosting this. I want to first begin by saying that I want to contextualize a lot of what Carla has been mentioning by highlighting an important aspect of documentation status on health and immigrant health in particular. And so if one can actually pop up the slides, I could actually begin by answering your first question by contextualizing everything within what is known within the Hispanic health literature. Hispanics generally tend to have health outcomes that are better than those of non-Hispanic white counterparts. So, for instance, according to the Office of Minority Health in 2018, Hispanics were 10% less likely to have coronary heart disease compared to their non-Hispanic white counterparts. They also were 30% less likely to die from heart disease compared to non-Hispanic whites. And this is despite having Hispanic Latinos having higher rates of obesity, diabetes, and hypertension. Hispanics tend to also be exposed to higher psychological and social stressors in the United States, but yet they tend to have lower rates of adverse mental health outcomes when it comes to major depression and anxiety. Of course, this is compared to non-Hispanic whites. And overall, despite a wide range of adversities such as low income, low education, attainment, as well as physical health challenges, Hispanics generally have lower mortality rates and longer life expectancy compared to non-Hispanic whites. And this is generally commonly known in the literature as the Latino Hispanic health paradox. Next slide, please. However, like much of the mortality and life expectancy advantage was reversed in 2020 due to COVID-19. Hispanics experienced disproportionately high COVID-19 mortality rates, and as a consequence, had an overall reduction in life expectancy of up to 3 years compared to the previous year. So if you look all the way to the left, you compare 2019 to 2020, there was a 3-year decrease in life expectancy. There was just 0.2 difference in life expectancy for white Americans between 2019 and 2020. And then for Black Americans is about 3 years difference or life expectancy reduction. But what I'm pointing out here also is that much of the advantage in life expectancy between Hispanic and non-Hispanic whites was washed away due to COVID-19. Next slide, please. Now, despite these sobering statistics, they don't paint an accurate picture of Hispanic health, given that it's an aggregate of multiple Hispanic subgroups, basically in one category. Hispanics are not a monolith, as many of folks in the audience know. They express a diverse pattern of heterogeneity when it comes to national origins, cultures, history of indigenous colonization or African enslavement, and even socioeconomic and immigration status. And these are important features to recognize and fairly represent in Latino health discourse and research. And while there are growing research over the years that have largely illuminated within group differences in health, one area of Hispanic lived experience that has remained understudied is documentation status. Next slide. Currently, there are over 60 million people who identify as Hispanic or Latino in the United States. And next slide. About 13% of them, go to the previous slide, 13% of them are undocumented. Yet, there are a dearth of research to understand the health of undocumented immigrants and the social determinants that really contributes to their health. The little research that is out there, next slide, show that undocumented Latinos, Hispanics have poor health than their documented counterparts. Undocumented immigrants, regardless of duration in the United States, report poor self-rated physical health, higher rates of hypertension, poor mental health when it comes to higher levels of depression and social isolation, greater generalized anxiety disorder, greater post-traumatic stress disorder, and greater emotional distress compared to their documented counterparts. And lastly, there's some very, very little research here, but the positive research that's out there actually show that undocumented Hispanic women have higher rates of low birth weight infants compared to their documented counterparts. If we're going to operate with these findings, the question then becomes, next slide, what explains these disparities between documented and undocumented Latinos, Hispanics? We first have to recognize that these differences are rooted in structural racism. Next slide. And this model really helps illustrate what I really mean by this. The likelihood of someone receiving refugee status or asylum in the United States largely depends on one's nationality and the color of their skin. Undocumented Latinos who are escaping persecution, for example, face far more barriers than white Europeans of past and present with similar reasons for migrating. And what's the tragedy of in all of this situation is that many of the reasons for a large number of Black and brown undocumented people coming to the United States have largely stemmed from U.S. foreign policies. Structural racism shapes policies and laws. According to the Brookings Institute, today's largely Latino undocumented immigrants, I quote, face far harsher consequences than white Europeans of years past for the same exact offense of unauthorized entrance to the United States. They're more likely to be apprehended, and once apprehended, there is no statute of limitations for unlawful status. And today's undocumented immigrants are ineligible for virtually all public health and public benefits, even though they pay taxes into the system. These laws and policies affect health outcomes of undocumented Latinos and immigrants in multiple ways. One of which that many of our actually succeeding speakers will talk about is the quality of healthcare that's being received by undocumented immigrants. They're more likely to face poor quality of care. They have to actually show proof of residence. And then there's also high levels of implicit and even explicit bias within the healthcare system towards undocumented immigrants. Undocumented immigrants are more likely to live in deprived neighborhoods where they're exposed to high levels of environmental toxins. They're also, given that they live in deprived neighborhoods, have restricted economic and educational opportunities in those areas. And a lot of the work that we're doing right now is how these laws and policies begin to actually shape health outcomes through stress. Undocumented immigrants not only face fear of deportation, which is a stressor that leads to a wide range of physiological dysregulation, but it also leads to a lot of financial stress and additional exposure of discrimination. So what I'm trying to say here with this model is that there needs to be multi-level interventions and programs to ease the effects of documentation status as a social determinant of Latino health. And recognizing documentation status as a social determinant of health is an initial step toward building programs and interventions. And as we continue to learn about the impact of documentation status on health, multi-level efforts, much of which will be discussed by our next speakers, can actually help buffer the effects of documentation status on health. So thank you very much.
Well, thank you, Adolfo, for sharing those significant findings and for reminding us all that Hispanics are indeed not a monolith. Now, I would like to invite Helen, a fellow Ecuadorian and New Yorker. Helen, as Chief Executive Officer, can you please speak on the work that New York City Health and Hospitals does to ensure quality of care for New York City's undocumented population?
Yes, good afternoon, everyone. Carla and Alfonso were basically saying here at Health and Hospital, we are actually building up on the research and what the literature is saying. So I don't know if we can start my PowerPoint so I can go a little bit over it. So this is a little bit about Elmer's Hospital in the next slide. You can see we are a hospital that was built to serve. We're part of the largest public health system in the nation, which is Health and Hospital. And our overall mission is to serve all those that walk through our doors, regardless of the ability to pay. And the next slide is a little video on our community. So hopefully you'll be able to see it. So as you can guys see, most of what Alfonso and Carla were talking about, we are in a very diverse community from the video that you can see. 15% of our community lives in poverty. Interesting facts, 57% speak another language other than English. And some interesting facts, Google Translate can only do 109 languages. Here at Elmer's Hospital, we do 125 different languages, which represents anywhere from 92 to 95 different cultures and religion. Data shows that not only are we the most diverse borough in New York City, but we're actually the most diverse borough and zip codes in the United States. If you go to the next slide, coming with that, it's some serious issues, kind of like what my other guest lecturers have been mentioning, is this whole idea of quality of care. And how do we help our population get access to healthcare to kind of reduce some of these social determinants? So as you guys can see in these three slides, one figure is the percent of uninsured among adults. The one in the middle is the percent of limited English population that we have. And then the third figure has to do with the percent of adults reported not getting access to healthcare because of cost. And if you really look at where the dark blue areas are and the dark green areas are, and you remember the pandemic, it's no surprise to you that these 7 zip codes are not only the 7 zip codes that we serve here at Elmer's, but also they were the epicenter of the epicenter during the pandemic. Next slide. So knowing this and understanding what quality means, what access means, what our mission means, and kind of seeing this data that we got from PCDC, we had to take action. So we really did, and we made data upfront. We took a lot of the data that we are preventive services to make sure that primary health care access was being done. So we took this data and plotted in there. We took the type of payer mix because we wanted to make sure that the communities that were walking through our doors had the ability to qualify and get screened for different types of health insurance, for different programs that we have here in New York City. We have the New York Cares program that regardless of immigration status, you can qualify for. We also have a sliding fee scale here. So we wanted to reduce some of that burden. Another thing that we did was mapping. So you could see here, we have 2 different versions of mappings. And what we did is that we wanted to map and really tiger focus on areas where we saw social determinants factors and indicators were high. But not only did we do make data our friend, we also joined, you can go to the next slide. We also joined the Equity Action Plan with New York City, with the Department of Health. Not only did this help us really get our data aligned to what we were doing inside the hospital, but we also aligned ourselves to what New York City was doing as well. So in that partnership, we were able to leverage the data and also leverage our resources that we have. Because again, we're a public hospital. We don't have a lot of funds, but the little funds that we do, we wanted to make sure it was getting to where it was needed. Next slide. I think you can hit the tab to get all of them in. Oh, it didn't all come through. So one of the things in this slide that you'll have noticed is that this slide was more about partnership. We wanted to create partnerships with different groups to ensure public and advocacy was being done, not only for vaccination, but also for the workforce. Another thing that we wanted to make sure in the partnerships that we were creating with our community members, both elected officials, government, and not-for-profits, is that we all had the same language when it comes to speaking about masks, about correcting the misinformation that we have there when the pandemic hits. We wanted to make sure that there was access to rapid testing. We wanted to make sure that people understood how to use telemedicine and when to use telemedicine. We also wanted to make sure that the infrastructure was there for our community members, not only for right now, but also for the post-pandemic recovery stage and also for the future. Because, one of the things that I found most interesting is a lot of people wrote about the pandemic and us here at the epicenter kind of saying, oh, look at all these cases, kind of like what Alfonso was saying. Our Hispanic community was hit so hard by the community. There's so much lack of access to healthcare. And for some odd reason, people were surprised. But for those that were here, boots on the ground, this was not surprising for us. We knew there were social determinants of health. We knew there were disparities in access to healthcare. What COVID kind of did is really put the spotlight on it. And that's where I think the opportunity came when it came to partnerships. So hence why I'm putting the emphasis on partnership and making sure our messaging and our resources were gathered in and focused together. And you can go to the next slide. So what happens when you get laser focused and you join partners with the same mission and the same laser focus as you have, you get the results that you get here. In the borough of Queens, we were at 93% vaccinated status. That is huge for a borough, for New York City being so big. So I am very happy to say that, Elmer's Hospital took a nice partnership. And I like to take that 93% of our community being vaccinated, where we were hit so hard with the pandemic, it was a huge success of partnership and being laser focused in putting our resources. And if you see right next door to our vaccination demographics by groups, you will see that Latinos here in the borough of Queens were 81% vaccinated, and our Black community was 64% vaccinated. And that is a huge accomplishment when you guys look back and remember all the misinformation that was given out to our community versus TikTok, Facebook, the WhatsApp groups. I mean, this was a huge, huge win. And I just wanted to end with, one of the things that my colleagues on the panel have been mentioning. When you take quality and you take data, that's only one step. Once you take the next step is partnership. You got to make sure that data becomes actionable. And it only becomes actionable when you become laser focused in what you're trying to help your communities in.
Thank you so much for this information, Helen, and thank you for the work that you and all H&H employees are doing to meet the needs of Elmers. Lastly, I would like to invite David to this conversation. David, can you please shed a light on the challenges that Latinos experience when navigating California's healthcare system?
Absolutely, and thank you for having us here, being able to share what happens in the Congresswoman's district, California 40th Congressional District. Hopefully we'll give some real life examples of how this works and how these partnerships and come into play. So if I can get the slide up, that'd be great. I'll go to the next one. There you go. So let's talk a little bit about what the space that we're occupying. The 40th California Congressional District is right in the heart of Los Angeles. The population is 715,000, with 82% being Latino. This is a community that traditionally has been seen as an African-American community. And with demographic changes in Los Angeles and nationwide, you can see how things have transformed here. However, the poverty rate is still estimated to be at about 21.8%. So for South Central Family Health Center, we actually have 25,356 patients in the district. And specifically, 40% of the patients that we have in our clinic and we address we estimate to be undocumented. We don't collect that data directly because we want to ensure that there is trust built between the clinics and our patients. And so therefore we calculate this out, this estimate of 40% of undocumented patients, because those are the patients that don't qualify for an Affordable Care Act or other sort of public insurance Medicaid program in California. Next slide, please. With that context, I want to talk a little bit about what we've been discussing today. The barriers that Latinos experience in accessing healthcare in California is very similar to what's happening nationwide. It's complicated. We're talking about issues of cultural competency, access to specialty care. As a federally qualified health center, South Central Family Health Center provides access to a whole range of services, from primary medical care to dental, to behavioral health, to vision care, as you can see in the picture here. We have mobile units out in the field. And all of that together helps provide at least a modicum of basic services to the community. However, if we discover through our screening processes or through our primary care interventions that there is specialty care need, somebody needs a cardiologist, somebody needs something more specialized, we still experience a great amount of challenges in being able to connect our patients to that care. And that means that there's a lack of equitable accessibility within the healthcare system. We'll talk about that a little bit more. Next slide, please. While I could say that things are difficult for Latinos in California, they're actually better than they may be nationwide. And I want to shine the light on this a little bit because, as you can see, healthcare expansion nationwide, we all think about the Affordable Care Act. However, in California and in Los Angeles County, where we're located, there have been additional expansions and closing of the healthcare access gap for undocumented persons and Latinos. And so I'll talk about this a little bit. Let's go to a little more detail. Next slide, please. When the Affordable Care Act was passed in 2010, this County of Los Angeles also had a program called Healthy Way LA, which is a free public health program that is administered by the Los Angeles County Department of Health Services that allowed clinics like South Central Family Health Center and other federally qualified health centers to provide care for undocumented persons. As we looked at expansion, the programs expanded. 2014, more patients became more eligible for Medi-Cal, for example, for young children and things like that. And new programs emerged to close the gap, like My Health LA in Los Angeles. Next slide. We've seen an acceleration in the expansion of access for undocumented persons in Los Angeles. On statewide with SB 4 in 2015 that eliminated the immigration status requirement for Medi-Cal eligibility for California residents 18 and under. It's a wonderful example of how federal policy still needs the flexibility when applied in the states to meet our needs. We have a large number of undocumented persons in California, and so therefore being able to, in our state, sort of adjust how we apply the program is really critical. So that meant that California residents 18 and under who, regardless of the documentation status, were now able to get Medi-Cal in our state. That's the Medicaid program. We extended that eligibility in 2019 through the Senate Bill 1014, which now meant that young adults ages 19 to 25 were eligible based on income now could get Medicaid because of this expansion. And in 2020, this last year right now, we were now able to expand all income eligible residents age 50 and older, including undocumented immigrants for full-fledged Medi-Cal benefits through AB 133, and this was recently included in the governor's budget for the 2022 year. So what you're seeing in California, and I'm not saying it just because I'm from the state, we have tended to trend ahead of the rest of the nation. Latinos continue to have extreme challenges in being able to access, healthcare services across the nation. However, what we're seeing in California is that when a dedicated legislature thinks about undocumented persons, regardless of whether they're voting or not, but because they're human beings and they need access to healthcare, we can actually do things on the state levels to support what is happening on the federal level in terms of expanding health access. Next slide, please.
Thank you for that. And before moving forward, David, could you please tell us what role do South Central Family Health Center's community health workers have in bridging the gaps in quality of care?
Great. Yes. The number one thing that we do is that we are able to hire from the community. And so for us, 51% of our staff comes from the communities we serve. This is critical because at least in places like Los Angeles, New York City, Chicago, and places in Texas that have a high number of competent, well-educated Latino community health workers or in the health force, we can bring that cultural competence. In other places in the country where you don't necessarily have those high numbers, having community health workers makes such an important difference. It means that you're bringing people into your health centers, your clinics, into your hospitals that have the same lived experience, cultural humility, and who look and sound like the people that you're trying to serve. In this case, Latinos Latinos in the United States. It's so important to be able to build that trust, and it's easier to build trust between patients and healthcare workers when you look the same, when you sound the same, when you have the same lived experience. Those things go a long way. Can I get the next slide, please? Challenges nonetheless remain. Community health workers, and like our staff at South Central Family Health Center, can help bridge the gaps in health literacy when we're talking about undocumented persons. There's people who may not have been acculturated in the United States, have a different experience in the relationship between the provider, a medical provider, and the patient. So having cultural humility is really important. We still have the challenges with access to specialty care and a lack of equitable accessibility within the healthcare system that I think hits spot on when he's talking about implicit bias and some of the structural racism that exists in our systems. But I think when you see what's happening in California is that there is hope for the entire nation. As we address through policy and through practical application in our clinics and hospitals, the will and desire to meet the needs of human beings where they're at in communities like South LA, in community health centers that are places of care in their backyards. When we decide that we want to do that as a society, because people deserve healthcare regardless of their documentation status, and by virtue of being human beings, we can make real changes. I say this because if you think about some of my wife's family members who are in Nebraska or in some of the central states of the United States where we may not have a large population of Latinos relative to the size of the state populations. There are opportunities for change. As demographics change, as the interest and the public will changes, California has shown that we can do better. We were the state that passed Proposition 187 almost 30 years ago that wanted to outlaw any sort of public services for undocumented persons. And here we are today, leading the nation in many ways when it comes to creating access to care. So with that, I will just reserve the rest of the time back to you, Michelle. And if anybody has questions, I'd love to address those.
Wonderful. Thank you so much, Mr. Amon, for sharing. And thank you for ensuring that South Central Family Health Center promotes inclusivity by ensuring that its workforce reflects the community they serve. Thank you.
Thank you.
So at this point of the program, we'll be taking questions from the audience. And I would like to direct the first question to Helen. Fatima asks, how has the COVID-19 pandemic contributed to the health needs of immigrant families?
So sadly, the pandemic hit Black and Brown community 3 times as hard. And one of the things that it did, when you're not feeling well and your health is compromised, you can't work, you can't go to school. So a lot of our youth got stuck behind educationally. A lot of our community couldn't work. So when you don't work, what happens? Housing and food insecurity become a big issue. So it hit our community in a trifold. I would say it hit us socially, mentally, and health-wise. But I would say one thing about COVID. While all these things are horrible, I do want to say in the communities here in New York, and I still live in my community, I still live in Corona, I do want to say it did get us closer. I think we saw more neighborly love. I never got close to my neighbors as much as I did during the pandemic. We would wear a mask, but I would make sure my neighbor, who was much older individual, I would make sure that I would get food for her, even when she couldn't afford it. I would make the food pantry lines for her because I know she was too weak to get it. I think there was more of a partnership and collegial in our communities, because I think in most Latino and Black communities, we do care for each other. We do care for our own. And I think when the pandemic hit and the access of vaccines, the access of food pantries, the access of housing vouchers, when it came to rent control, I think we really got together and advocacy started working. I felt like there was a lot more advocacy going on in our communities. So that's one positive thing that came out of the pandemic. And I think that advocacy has still stayed on. I think the fact that our communities of colors are saying, ya basta, we need good access of healthcare. Not only do we need good access of healthcare, we need excellent healthcare. Just because the people in Park Avenue have great access to healthcare, that doesn't mean we should get crappy. That's why I love David. I love FQACs, because really they give access to healthcare in such a dignified and respectful way to our communities.
Thank you. Thank you for that, Helen. And we have our second question now directed to David. Can you share more about the importance of, can you share more about the importance of and challenges in ensuring culture competent care for communities of color?
Absolutely. I think this is one of the foundational, stones for being able to provide care, which is, we're talking about cultural competence as a starting place, which means that you respect other people's differences and you understand that you may have biases that you need to overcome. It's a great place to start. But we're really trying to approximate is cultural humility, when we really understand what we lack and how to create bridges. When you're talking about communities that may not be native to the United States, for example, in Los Angeles, we have Zapoteco populations that are indigenous from southern Mexico, and their first language is not Spanish. It's a native indigenous language, Zapoteco. They come to Los Angeles and as to find work as human beings, and they need healthcare. What does that mean? It means that we don't make assumptions that they speak Spanish because they just came from Mexico. It means that we also understand and build upon a structure that there's an unequal relationship in Latin America very often between healthcare providers and patients, where people just listen and don't actively participate in their own care. And here in the United States, this is the model that we employ, the provider-patient alliance. And so really being able to understand that we start at different places, we need to meet people where they're at, very often requires us as healthcare workers to understand where we are in that landscape first, because we can't build bridges if we don't know where we are.
Wow, powerful response. Thank you, David. And our last question for today will be directed to Carla and Adolfo. That'll be, given the existing racial biases, what would you recommend for gaining the undocumented community's trust and attracting them to currently existing free healthcare services?
Thanks, Michelle. I'll take a stab at this. I think that the first thing that people need to think about is to make sure that people who are undocumented who are coming to your clinic or your office, that they know that they're safe. The FQHC that I used to work in used to really go out of its way to make it very, very clear that this was a safe place for them to come. Nobody's calling the police. If you don't have the right documents, you're still going to be seen. If you can't pay, you're still going to be seen. The point is we are neutral. We provide health care. You are in a safe space. So it's critically important, I think, that that message gets out to the community. The other thing I would say is that healthcare in general has a problem, and that is that many think that just having the best medicine, let's say, or the right clinical approach is sort of the whole game, but it's not. A critical part of good care and helping people get better is to build relationships with them. So if you take the lens of building relationships at every point that a person has an encounter with a healthcare system, right? What does it look outside the clinic? What is it like when they walk through the door? Does it feel welcoming? How did the front desk treat them? How does the nurse treat them? How does the doctor treat them? Like all along the way, if you take that frame of building relationship, then people feel welcome and hopefully they trust and they're engaged. Because it doesn't matter if you diagnose them correctly and give them the right medicine, if they feel scared or they don't trust, right? You've made a mistake there. And the last thing I'll say, and it's really just kind of echoing what my colleagues have said, is that you need people who come from the community to work in the healthcare setting. And you need to actually actively reach out into the community and invite them in and understand what they want. You need to get ideas about what they think will improve their health. And then you need to actually act on that information and transform how you deliver care.
Wow, thank you.
That was wonderful, Carla. And I guess just to piggyback off of that, there are actually, I would say, 3 areas by which we could begin to address many of these issues. For one, has been echoed by the panelists here, which is representation matters in terms of improving cultural humility within the healthcare system. But then I also would add in reducing racial bias head on by highlighting the issues of racial bias within the healthcare system. Many staff and clinicians do not know or are not aware that they're actually holding racial biases. And by having racial programs that addresses racial bias will help improve trust within this community. But I would also say, maybe this might contradict what I just said, and I think by focusing just on the healthcare system basically places a band-aid on a large wound. And in order to begin to repair this huge wound is to actually begin thinking about policies. And there, I think this is where I think we all could agree on that. I think a city level response to basically implementing sanctuary city policies will actually help foster trust, not only for undocumented, but also documented Latinos and Hispanics, where mistrust is still very large within our community. So I think these policies itself can actually have a spillover effect, not just within the healthcare system, but also within the education system. And in turn, this can actually improve population health for all.
Wow, thank you so much for sharing, Adolfo. Well, now that we're ending the end of our conversation, I would like to ask the panelists one last question, and that would be, if you would have our audience take away one thing from today's panel, what would that be? And we could start with Carla. Please take it away.
Thanks, Michelle. We need to focus. The time has come to focus on health equity and reducing disparities and equitable care. So I think everything we've talked about today has given us some ideas about how we might do that. And I hope people will take that away from this conversation.
Perfect, thank you. Adolfo, any closing thoughts?
I would say that documentation status is a social determinant of health, and we have to begin to acknowledge it in order for us to recognize that this is a huge part of the Hispanic Latino lived experiences. And by doing so, we'll be able to develop equitable interventions and prevention measures.
Yes, completely agree. Thank you. Helen, would you like to share a few words?
I think I just want to acknowledge the hard work. This is not easy work. This is very hard work. This is work that sometimes we won't get the thank you for. It's work that um, that we could work our whole careers towards and won't see the progress, but know that the progress is there. Know that the impact on one policy change could affect millions. And if you just take the undocumented part, we're 7.6, I think Adolfo said 7.6 million of our community members are undocumented. So if you think of how one policy can change that 7.6 million, the hard work is worth it. So that's why I just want everybody on this audience to remember is that the hard work, the late nights, the hard thinking, the sacrifice is worth it because 16 million people are counting on you.
Yes. And David, please share with us your closing remarks.
My closing remarks are quite simple. Good policy makes a difference. Here in California, we are showing that we can close the gaps in access to care so that we can focus on things like health equity and racial structural racism. It's possible, it's happening. And the more that we take that approach that things are possible, we're doing them. And as Carla just, sorry, as we just talked about right now, this is hard work, but change is happening. And so change nationwide is possible. And it is reinforced by good policy and a lot of good hard work.
Thank you. Thank you so much to all the panelists for engaging in a challenging yet necessary conversation today. As we strive to improve the quality of care that's provided to undocumented immigrants, it is imperative that policymakers take into consideration a few actionable steps, such as incorporating cultural competency trainings, increasing the use of high-quality interpretation services, and integrating survey criteria that assesses discriminatory experiences. I would like to share that as a daughter of undocumented immigrants, I have witnessed my parents and others in underserved, under-resourced communities refrain from utilizing healthcare services due to their either limited access to health insurance or fear of costly medical expenses. However, I'm also very fortunate to witness an onset of progressive policies and interventions, both at the local and state level, that ensures undocumented patients receive the care that they deserve. I would now like to take this opportunity to thank the CHCI program and all of the CHCI fellows. I would also like to thank all the staff members from the Office of Congresswoman Lucille Roybal Allard for their continuous support. And lastly, quiero agradecer a mi madre y padre que por su esfuerzo tengo el privilegio de poder estar aquí y apoyar a la comunidad inmigrante. Please make sure to tune in for our last CHCI briefing today with Tanya Calle, taking place later this afternoon. Thank you.